First of all, I just wanted to introduce Professor Andrew Dickenson. We're incredibly lucky to have managed to persuade him to do our inaugural webinar today. He's the Chief Dental Officer within Welsh Government. He's dual qualified as both a dentist and a doctor, and has had over 33 years as experience as a clinician within the NHS. He's had a very varied career with education, management and healthcare leadership. Prior to joining Welsh Government, he ran a tertiary MaxVax service specialising in paediatric head and neck surgery. He seems to have done absolutely everything. He's also, between 2014 and 22, was the Postgraduate Dean for Health Education England. And he's got a really interesting broad experience within health policy, and particularly looking at how you monitor systems. He's very interested in human factors, widening participation and leadership development, which we can all see through this today. His personal research interest is service planning within rural and coastal settings, which would fit perfectly within Wales. And he's also a visiting professor at both the University of Chester and also the Coventry University. So without further ado, I'm going to hand over to him, but I just wanted to first, before we start, just to say thank you so much for allowing us to invite you for our very first webinar. I'm really happy to have you here.
Claire, thank you very much, and good afternoon, everybody. And it didn't take any persuading at all. It was very kind to be invited. I'm absolutely thrilled to be here today to talk really about something which is a passion of mine, and something which, unfortunately, when we talk about healthcare, oral health is rarely part of that conversation, and I think it should be. So maybe today could be quite a pivotal time for us to reframe how we think about oral health. Neglecting oral health doesn't only harm individuals, but it ripples across our communities. It inflates our healthcare costs, it widens inequalities, and it actually undermines our general well-being. And in particular, when we talk about children, it has such a profound impact at an early age. It impacts on education attainment, socialization, and then it has the wider impact on the families in terms of taking time off work to take children to appointments. And it adds to their general other lifestyle burdens. So today I'd really like to unpick some of this with you and try to emphasize why good oral health is central to our overall well-being, that it shapes both the quality and the longevity of our lives. And that, of course, starts exactly in childhood. As Claire kindly said, I'd like this to be very interactive. I would love you to ask lots of questions in Menti. So when I finish this brief overview, we can really start to get into the depth of this topic. I am going to try and anticipate some of those questions as I go along, but don't worry if you've asked a question and I answer it within the presentation. Some element of reinforcement is always very important. But first, I'd like to set you a challenge. If you've managed to download the Menti, I've got 3 very quick fire questions, really just to sort of get us going. Don't think too much about them, and I will explain the context to these as we go through. The first question, a little bit tongue-in-cheek, is what would you rather, brush your teeth or brush your hair? And there's a connotation to this, and so I'm really pleased that people are actually spreading their votes. I'm going to move on to the second one. Keep on voting on this, but you can move on to the next question, which is how often should our teeth be cleaned? Are you a once a day person, twice a day, only when we remember, after a meal, or, as we probably should, just before going to the dentist? Then our third question, please keep voting. Our third question is, how often should an adult, and I stress the adult part, have a dental checkup? Is that every 3 months, every 6 months, every 12 months? What about 24 months? What about when we're told by our dentist? Cost obviously has an implication in this, or do we just go when we're in pain? And you can choose more than one answer to this one. So thank you for doing that. I'm going to skip back to our very first question and just have a little look at the distribution of the answers. So, would you rather brush your teeth or brush your hair? Well, I'm actually quite pleased for an informed audience that you are looking after your teeth. But I think the 15, 16% that are saying brush your hair, there is actually a lot of evidence for this. So, Women's Hour on BBC 4 recently published a report where they showed that ladies spend over 40 minutes a day on their appearance. That's hair, makeup, clothing, exercise, keep fit. Um, so we put a lot of emphasis on our general appearance. And while 71% of us brush our teeth, the recommended twice a day, there are 27% of the population that only brush once a day, which means that there are 2% of our population which brush less than once a day. 27% also brush for less than 1 minute, where the recommended is 2 minutes a day. Um, in terms of actual cost, the Women's Hour report also showed that the average British adult spends £71 a month on their appearance. And in particular, they spend £378 per year on their hair. Now, when we ask the same question about how do you look after your teeth, 26% of the population state that they change their toothbrush less than every 6 months. Bearing in mind that you can buy a toothbrush from any supermarket for £1, or sometimes less, that isn't proportionate to how we spend on the rest of our appearance. When the question is asked how many people have had tooth whitening, 40% of under 35-year-olds have undergone that procedure. And when we look at that in how much we spend on our oral health per year, the average for an adult is around about £200 a year. If we compare that to the £850 a year on our appearance, we can see there's quite a disproportion. But within that £200 on the oral health, most of that is on cosmetic, dentistry, and tooth whitening. So I think, we do value our appearance, but we don't see teeth as being part and parcel of that. How often should we clean our teeth? Exactly. Most members of the population would try and brush their teeth twice a day. 71% of adults brush twice a day. But the Oral Health Foundation tells us that only 75% of children brush twice a day, but 25% of children brush less than twice a day. And I think this is a great concern to me when we're talking about developing a lifelong behavioural habit of looking after our teeth. We need to really encourage that behaviour of at least twice a day. Now, when you do it, is quite fascinating. The advice is you really should brush your teeth before breakfast because of the bacterial load that accumulates in our mouth overnight. So we should be advising people that we come into contact with that they should be brushing in the morning, ideally before breakfast, and particularly for children before going to bed. If we can increase that frequency to after every meal, that would be particularly helpful. But we're aware that's very difficult when it comes to the busy lifestyles that both children and parents have, and it adds additional demands on the school day. I also agree with somebody who said brush before going to the dentist. I think that makes the dentist's life a lot more pleasant. And what about having an adult dental checkup? This is really quite an interesting point. The advice has always been that you should go for a checkup every 6 months, but that changed over 20 years ago when NICE, the National Institute of Clinical Excellence, it indicated that really this should be based on a needs and risk basis. So really taking advice of when instructed by the dentist as to when you should be having those checkups. But for over half of our population of adults, this is probably now about once every 24 months. And this is reflecting how oral health has been improving through education, through the support that patients get from their dental practices, but also by raising health literacy. So we should be saying that for adults, somewhere between 18 and 24 months is now the sort of the average, but that's based on instruction from the dentist. But that's very different for children. And children, we are still recommending, should actually see the dentist every 12 months up to their 18th birthday. And maybe we can pick up on the question how people get in to see a dentist on that frequency. But I've talked a lot about oral health, and oral health and dentistry are slightly different. Oral health has this definition, which has been created by the World Health Organization, and it splits it into two components. There's a functional element, and then there's the psychosocial aspect towards oral health. So in its broad sense, it's the state of our mouth, the teeth, and all the oral facial structures, which includes all the soft tissues inside of the mouth, which includes the gums, right back to the tonsil area. It also means looking at the lips. And then it's about what the individual gets out of having good oral health. So it's essential for a lot of our functions, particularly not only just our appearance, but also the way we eat, the way we breathe, the way we speak. And that influences our self-confidence, our well-being, our ability to socialize, and essentially to work without any pain, discomfort, or embarrassment. So it's a very, very wide concept of oral health, which is different from talking about teeth, which is where we normally associate dentistry to lie. And so I tend to look at oral health as something which starts at birth, probably before birth, and it goes all the way through to the end of our life. And it's quite important that we sorry, I just went on to mute there. So dentistry addresses oral health when it's gone wrong. So let's have a little look at what actually we mean by oral health. And the top left picture shows teeth, and these are baby teeth. And for those who haven't really seen tooth decay before, this is where we get the damage to the outer white coating of the teeth, the enamel, and it eats into the tooth itself. And that causes the decay. The decay, if it goes down to the nerve, starts to get into the nerve system, and that's where people develop toothache. And I think it's very important that we are, as health professionals, able to recognize what tooth decay looks like, and this is a very good example. But it's more than that. It can affect the gums, and that leads on to gum disease. And while children tend to be relatively protected from gum disease, if we don't establish the right behavior and the right patterns of looking after our whole mouth in childhood, then this extends through into adult life, where there's less observation of what we're doing on a day-by-day basis. So I think it's important that that we pay attention to both the teeth and the gums, and of course we can do that by simple techniques such as toothbrushing twice a day in a supervised manner in childhood. But there's more than that. You've probably seen children with tongue ties. And for me, this was very important in my clinical practice, where I ran an infant feeding clinic for about 15 years, that there are simple things that we could do right from birth to ensure that some of the other policy directions that add to the quality and of a child's life, such as breastfeeding, can be established right from the beginning. And simple things like releasing a tongue tie when it's interfering with maternal breastfeeding is incredibly important, and again can be seen just by looking in the mouth. We see children with congenital disorders such as cleft lip and palate, and of course those children will need to have a regular relationship with the dental profession, because they're going to need that care throughout the whole life. We see a lot of trauma to teeth. And this is one of the biggest problems in childhood. And so identifying trauma and getting care for that at an early stage is very important. And then the bottom right picture is something which probably many people haven't seen, but it's on the rise, and that's mouth cancer, and particularly oropharyngeal cancer. So I can hear you saying, well, why are you talking about mouth cancer when we're looking at children's oral health? Well, we've identified that the human papillomavirus is now responsible for the vast majority of oropharyngeal cancers. And so as we're looking at the whole child pathway of care in early life, we've really got to think about the vaccinations, and we've got to think, are these children that we're coming across actually being vaccinated appropriately, not just to all the common childhood ailments, but particularly to the human papilloma virus. And we know that if we don't get on top of HPV at this early stage in life, it's probably going to take another 25 to 30 years for the vaccination program to almost reduce or eradicate the risk of oropharyngeal cancer. So how do we impact on our oral health? And these are some of the commonest ones. Alcohol use in young people is becoming less than it used to be, but it leads to a lot of childhood trauma, damage through injuries, and also this sort of general neglect of their physical well-being. Smoking is still a problem, and that has significant problems on our oral health. It has not only the various chemicals within the smoke plume, the carcinogens that are put into tobacco, but nicotine itself is a vasoconstrictor, and that starts to affect the health of the gums. Vaping is becoming a significant problem. And if we take on board the advice of Chris Whitty, the Chief Medical Officer in England, who's very clearly stated that vaping is an excellent substitute for smoking, but it is not to be taken up for any other reason. And yet we've got over 1 million people in the UK who have never smoked and are vaping. And social media has a lot of responsibility for that. It's impacting on the way that children start to interact with various substances. And we've got to be very much aware that within the health literacy, when we're dealing with young people, is to explain that why vaping is not something that they should be taking up. But this in itself has a significant problem on our oral health. Unlike tobacco, there isn't any convincing evidence yet that it leads to the development of mouth cancer, but it does dry the mouth. And we need saliva not only just to lubricate our mouth when we're speaking and when we're eating, but also it protects the oral structures because of the various antibodies that it contains within our saliva. It's also the smoke or the plume that comes from vaping is very acidic, and that causes gum disease through the vasoconstriction effects, so very similar to alcohol. And then the other big one is sugar. Sugar is a real concern for us. And as we know, we are a nation which enjoys sugars. By the age of 10, most children are consuming an adult daily maximum dose of sugar. If we measure it in sugar lumps, the average 10-year-old is taking at least 8 to 10 sugar lumps per day, which doesn't sound a lot, but that's a substantial amount when we look at some of our other challenges, particularly around healthy eating, because sugar being an appetite suppressant, but also in terms of the obesity problems that we have. And of course, most children are exposed to sugar at a very early age. And if we're going to give any advice to parents, there should be absolutely no added sugar given to under 4-year-olds. Between 4 and 6-year-olds, really their maximum intake should be around about 4 to 5 sugar cubes per day as an absolute maximum. By 7 to 10-year-olds, it should be between 5 and 6 cubes a day, but we should be aiming to really reduce that to the absolute minimum. But too many children are now exceeding their annual recommended dose. And then the top slide is the human papilloma virus. And I think we really ought to be looking at how we educate young people and the parents about all of these risks. What we do know, this is a paper published recently, is that young adults know more about their mental health than they do about their dental health. And not surprisingly, that leads them into doing body modification, which is becoming incredibly popular. So we've heard about turkey teeth, and we look at the picture label before and after. This is somebody who obviously hasn't liked the appearance of their teeth. For me as a professional, I look at the teeth and I'm not happy about the condition of their gums. but they've had full mouth veneers placed on these teeth, which has now committed them to a lifetime of dental care, because they've got to now seek professional help to keep the teeth and the gums healthy. So what appears to be a really nice aesthetic result very early on in life is going to translate into a lot of care throughout the life course. And of course, when we're talking about the economic impact, that impacts both on patients and on the NHS if we have to provide the care to maintain those non-essential veneers. We get the same problem with body piercings. We see a lot of piercings in the mouth, and of course those ball bearings tend to chip the teeth, cause dental trauma, and they're non-essential. They do not improve health at all. And the same goes for the jewels that we see going into teeth. That requires having to cut the teeth. So damaging that protective enamel, weakening it, allowing saliva, sugar to get in between the jewel and the tooth, and that's going to cause some damage. And then we also modify using Botox and fillers these days. And of course, that affects the structures, causes scarring, and that affects some of the way that we actually look and that we behave in society in terms of the way that we speak. It alters speech quality and lip competence. So while young people, it's great to celebrate that they know a lot about mental health. Once again, we've got to keep raising that awareness and the literacy around oral health. So what could be some take-home facts for us? Well, oral disease is common. Unfortunately, it shouldn't be, because it's both preventable and it's non-communicable. But it's affecting globally around about 3.5 billion people. And what we're noticing is that there is an increase in those low and middle income countries. So the ones that have currently been traditionally economically challenged are also now feeling the burden of things like raised sugar content. And that overall burden not only impacts on today, but it will impact on the future. Because once you have dental disease and you have to start having treatment for it, then it means that you're going to have to care for those fillings and the crowns and the dentures for the rest of somebody's life. And as we are an aging population, and the population will be around a lot longer, that has considerable impact on how we structure our future healthcare systems. So what I'm trying to say is that what we do in childhood is going to be so crucial to how we actually age as a society going forward. So what is happening in Wales? So we've got some brilliant data which is coming from our epidemiology groups. And we get regular reports from looking at the childhood epidemiological surveys of 5-year-olds. And so this is some of our latest data. And this is looking at tooth decay in isolation. But we're looking at both the prevalence, how much of it is out there, and then the severity of the tooth decay. And I think we should be very pleased that through a lot of the interventions that we've been driving over the last 20 years, that we're starting to notice that both the prevalence and severity is starting to decrease. But we still have around about 1/3 of our children affected by tooth decay, and around about 18% of those quite significantly in terms of needing hospitalization for tooth extractions under general anesthetic, or significant amounts of time off school. But that prevalence has been reducing between each of the surveys, and I think we should be very pleased, but there's still more work to be done. In terms of the severity, that is also showing a comparable decrease. But what we're showing that is in the children who have tooth decay, they do have quite significant tooth decay. It's not as severe in terms of going straight down to causing an abscess by going into the nerve area of the tooth. But it still means that they need treatment, and they need more than one tooth treating it at any one time. So when we then look at what does that mean and who actually gets these gets tooth decay, we notice that the inequalities element is magnified. So children from deprived backgrounds are experiencing higher levels of both the prevalence and the severity of tooth decay. And sadly, this really hasn't changed since we started doing the epidemiological surveys back in 2007, 2008. And it's quite stark when you compare the least deprived to the most deprived, where in terms of prevalences are only about 20% in the least deprived, but it's nearly 50% in the most deprived. And the same goes for the severity. The least deprived have less teeth affected, whereas in the most deprived, we are seeing that a number of teeth are affected. And this makes dental decay a legacy problem for us because the filling that's put in today will need to be replaced a number of times through that child's life. And therefore, we need services which are going to be able to cope with that. So I think this is my argument as to why we should be engaging with oral health, not just tooth decay, not just dentistry, but particularly oral health. And I wish to flag up a lovely article by Baroness Floella Benjamin. Most of us who have a long memory will recall that she was very pivotal in some of our childhoods in terms of being a presenter of Play School, and she has been a passionate advocate for children's oral health over the last 30 years. And she wrote a paper in the British Dental Journal where she emphasized that childhood lasts a lifetime. And I think that's a valuable strapline that I use a lot with parents. I also stress that oral health is you can't take it away from general health and our general well-being. If we don't have good oral health, we're unlikely to actually feel well in ourselves. But sadly, as the Lancet has said, oral health is often overlooked, and therefore this has ongoing lifelong impact on our children. So let's have a look at some myths then. So we know what's going on. We know that there's a real problem out there. We know that it's a complex interaction, and we know that it's a legacy problem. But I think we fall into a trap sometimes by saying that dentistry is responsible for oral health. It is to a large degree, but actually it can't do it alone. It needs all of us. Oral health is everybody's business, and the more that we can start to work with children, young people, and their families around the messaging that good oral health is something that we can all achieve just by doing some simple things such as brushing twice a day, using a fluoridated toothpaste, and being very careful with our diet, then it means that the dentists can then be released to actually deal with some of the disease, which unfortunately is still affecting a third of our population. Improving access to dentists will improve oral health. I hear this a lot, and it is a very valid point. What I would say is that improving access to dental teams would actually help considerably. We have very skilled dental team members at dental nursing, dental hygiene, dental therapy. If we can expand the access to those dental groups, will improve oral health. But I think we can do it ourselves. I think self-care is absolutely vital. We're not programmed to get tooth decay unless we're not exercising good self-care. So I think improving access to dentists alone isn't the answer to improving overall oral health. Oral health is only about brushing twice a day with toothpaste. True. I mean, we've got to brush twice a day. That is the recommendation. It should be a fluoridated toothpaste. It should be for 2 minutes twice a day. But we've also got to think about diet and behavioral modification. So it's not just about the toothbrushing, but that is an essential message I think we could be giving out. Teeth aren't designed to last a lifetime. Well, they are. And we've got to look after them. Too many people will go and buy a car and they'll spend all weekend polishing it and brushing it and washing it. But we should be doing the same to our teeth. They should last a lifetime. I used to hear a lot from people, from parents say, my child doesn't like milk. There is a cultural belief that milk is going to toughen up teeth. Milk is better than sugary drinks, carbonated drinks. But if a child doesn't like milk, that isn't an excuse to give them a sugary drink. Water is probably the best thing to advise parents to give their children. Sweet treats can't harm my children's teeth. Well, we know that they do, but we shouldn't be very austere. if we look at other countries like Scandinavia, they've socialized sweet treats to being a Friday evening treat for the children after their evening meal. So we've got a long way to go, but the readily availability of sweet treats do harm children's teeth. And that's where policy comes in, because obviously we've removed sugary snacks off the conveyor belt aisles in supermarkets, but there's still a lot more that we can do. And the other one is around my water's fluoridated and that protects my teeth. Well, sadly, we don't have a lot of water fluoridation in the UK. There's only about 6 million people benefit from water fluoridation out of 66 million, and we don't have water fluoridation within Wales. But we can use fluoride in toothpaste and fluoride in the varnish that we put on children's teeth, and I'll explain a little bit more about that in a second. So for me, it's a very complex area that we've all got a part that we can play. It's about education, particularly around diet and what we put into our bodies. That has a knock-on effect in a lot of other areas, particularly when we're managing obesity, but we're managing chronic disorders such as diabetes. And there is a very strong link between diabetes and gum disease in adults. And of course, that starts in childhood. This requires literacy, and we have a fantastic resource called Delivering Better Oral Health, which is a 4-nation document. It's available for anybody working in healthcare. It's not dentistry specific. And so Delivering Better Oral Health is something I would really like to signpost from this talk. It has a set of resources attached to it, which are readily available to use with parents and children. It's about us becoming more integrated in the conversation that we have. We all could have a conversation with children, young people, and their parents. And we don't need to be experts in that. We just need to start asking some basic questions, such as, how are you managing with your child's oral health? We can also help professionally because of the availability of fluoride these days, and that's built into some of our programs I'd like to talk about in a minute. We are trying very hard to improve service access for children. It's not right at the current time, but we are still managing to see around about 68% of our young people on an annual basis. Where the other 20 odd percent are is a bit more of our challenge, and that's something maybe we can pick up in the questions, and we're doing a lot of that through changing policy. So my other message is we've got to try and stop fixing the child. We've really got to try and fix the system that child is being born into, and that's going to start, for me, prenatally. We should be maybe having these conversations in antenatal classes and getting mothers into the concept about what feeding patterns are, what healthy eating is about, and how we start to socialize oral hygiene behaviors. And with that in mind, one bit of advice is really we shouldn't be allowing children to brush their own teeth before the age of 7. It should still be delivered by the parents. And I know that's very difficult, and any of us who are parents will remember the trauma of trying to brush our own children's teeth. But the guidance is the children don't have the manual dexterity to be able to brush their teeth twice a day in an effective way. And if we are going to give them a good start in life, then this is parental responsibility. After the age of 7, it should be supervised by the parents. So we shouldn't just let the children wander off to the bathroom alone. And I think that this is something which we could do through health literacy, because there are reported papers which state that most parents believe that their responsibility for their children's oral health ends at around about 6. So we need to be looking at that. But we need to also be looking at some of the other aspects, such as the socio-economic impact on families, and then that wider community perspective. So this is why in Wales we've been working on something called Design to Smile. This has been set out in the Welsh Health Circular. It's within policy, and it has a number of objectives, and it particularly works with young children between the ages of 0 to 7 and our professional partners. So there is a lot of advice going into health visitors, for example, and then at a later date into teachers and teaching assistants in schools. It provides the resources, so it provides toothbrush and fluoride toothpaste packs. And at the same time, going into school, it delivers educational resources in the classroom. It encourages supervised daily toothbrushing, which is led by the teaching assistants or the teachers. And the teams that go in from public health also do twice yearly fluoride varnish applications to the at-risk children. But in particular, we target schools and nurseries in very disadvantaged areas. And as a consequence, we're actually able to reach the objectives that I think are critical if we're going to make a lifelong change in terms of education, literacy, behavioural change, particularly around diet. And integrating it into more than it just being a dentist-led initiative. Just quickly, I just wanted to mention about access, because this is one of our big problems. If we rely just on dental access, the green graph on the right and the blue dots are where we have dental practices. We don't actually have NHS dentists in the UK. We have private businesses which contract with the NHS to deliver NHS services. And I think this is where we get a lot of confusion, that if we don't have contracts in areas of need, then we've got to think of different ways of delivering care. And self-care and the school programs are very integral to that ambition. But also working in a much more integrated fashion, what I call working at the borders. And this is where everybody in this call is so vital to getting that message out. We need to look at things in terms of the population-based programs. And so Healthy Child Wales and some of the other school programs are absolutely vital for us trying to start the conversation about what is good oral health. And I think it starts with thinking about what are the common risk factors that we all share, and are we actually all talking about them at the same time? But we need a population-based model to identify those at-risk families. And I think this is where Design to Smile has been incredibly effective, because we have a consistent message in line with delivering better oral health, and that is start brushing a baby's mouth as soon as the first teeth appear. Don't wait until they've got a full mouth of teeth. So even though we talk about getting a child to see a dentist before their first birthday, they've already got a substantial number of teeth in their mouth at that point. So as soon as that first tooth starts, let's start brushing. Brush at least twice a day, last thing at night and in the morning, using a very thin smear of fluoride toothpaste on a dry brush. You don't want it wet because you don't want the child swallowing any of this. And after brushing, if they're very young, just wipe around the mouth to take away any toothpaste. They don't need to rinse out. As they get older, we advise them to spit but not to rinse their mouth so that the fluoride stays on the teeth. But Design to Smile is working at a home level, it's working at a dental practice level, and it's working in nursery and primary school level. So it's covering that wider population focus. And while we would love to expand this program, it is still difficult to get that full coverage. But we are reaching out to around about 85% of our schools. And when we draw all that together, I think we meet the objectives of public health. And so oral health is integral to the functions of public health in terms of having a strategy which is focused on prevention, self-care, and integrating it into everything that we do, and ensuring that there is advocacy for good health policy. And that leads to the outcomes. And for us, that would be looking at disease control and a reduction in that disease within our population. But it's more than that. It's the empowering of the population to lead on a prevention orientated approach to their life. And the impact, of course, is that we end up with a healthier population. So I think for me, this graphic, it really summarizes that oral health should be everyone's business. So what other things are we doing? Just briefly, we're looking at decentralizing care. And there's been a lot of criticism about using mobile units to go out into the hard to reach communities, particularly in the rural and the remote areas. And this is something I've been doing a lot of work with in different parts of the UK. But in North Wales, we've been using the vans to go into schools. And these are led not by dentists, but by other dental care professionals. And in Powys at the current time, we've got vans which are providing the full range of dental treatment in sites which are very convenient for children and their parents to access. And I think it's important that we actually think if we're going to have high performing care teams, then we've got to think both on a functional and a cultural basis. Whereas the lower performing teams just focus on one aspect. And this is why I keep saying, while dentistry has an important role in maintaining oral health, that's just looking at the functional aspect. We've really got to think about the cultural change. And then just finally, we can do things through policy as well. So you're aware that we've been doing a lot around sugar taxation, incentives for healthy eating, and ongoing conversations around water fluoridation. But everything that we do is evidence-based, and it's important, therefore, that we think about what are we doing for a particular population, how are we targeting that population, and are we actually getting value for the care that we're actually putting in? So policy is just as important. And I think this really comes back to my starting statement, which is around preventing the preventable. We've got to do that together. And the current aspect I would like to raise around oral health is around oropharyngeal carcinoma, which is rising in men. We're immunizing against cervical cancer in women and girls. We're starting to immunize boys for the same reason. But we've got to keep promoting that. We've got to start having those conversations quite early on around their sexual health. So along with vaccinating against HPV, we've got to really discourage people from smoking, taking up smoking or quitting smoking, and cutting down on alcohol. Cancer Research UK is very clear on that guidance. And so again, all part of the oral health messaging that we can use with our patients. So in conclusion, what can we do? This was a graphic that came from a workshop that I ran at the Royal College of Paediatrics and Child Health this year. And it was fantastic to hear the key elements, which are we've got to be innovative, we've got to collaborate, but we've also got to advocate, and that together we can make a difference in terms of changing our oral health pattern across the UK, but particularly in Wales. So I've done a lot of talking, and I would like to hand it over back to Claire and over to yourself now, just for any questions. But this is slightly facetious, but you don't have to brush your teeth, just the ones that you want to look after.
That's wonderful. And I know, thank you, Andrew. Honestly, I could have listened to you all day. I have to say, I particularly like that last slide. I know you were debating whether to keep it in or not, and I said, no, I think it's perfect, because we all do want to keep our teeth, don't we, for a very long time. Just a couple of things to mention. I've put in the links to the documents that Andrew's referred to in the chat, so everybody's got access to that. But also Mary Wilson, who's a public health consultant working dentistry, has also mentioned about the Design Smile programme, and also given her contact details if people want to contact her. So lots of interesting comments in the chat. So the first question we've got is a good one from Matthew York. It sounds like access to dental care is a wicked issue, i.e. too difficult to tackle. What work is happening at policy level to ensure access to quality care on an equitable basis throughout the country?
Matthew, great question, and thanks for asking. It is wicked. It's why we refer to dentistry being one of the most complex systems that we deal with. So we are dealing with it in a number of different ways. If you've seen anything in the media recently, that the biggest concern is around the NHS dental contract, which isn't incentivizing dental practices to see patients. So we've spent the last 12 months working with the profession on what would be an ideal dental contract that would encourage practitioners to see more patients under the NHS than on a private basis. But we also don't have any control over where dentists are distributed, as the map showed. People are free to set up their practices wherever they wish. A lot of the time they take over existing dental practices. So it doesn't actually have a population distribution. And that is why we have so many areas of under-resourcing within our communities. And as we move up the country, it gets more prominent as we move through Mid and North Wales. So we've been expanding the training, and we've actually been focusing on the other health professionals, because the dental hygienists, dental therapists are a lot more agile in terms of working in these remote areas. They're more adapted to working on mobile units. So we've been looking at how can we commission more mobile centres which go out to the individual communities. As these communities are quite small, it means that we could place a mobile van for only a few days, maybe a week, and people will know that resource is available during that time, and we can see them for an assessment. But just to be clear, the vast majority of adult patients that we see don't need any dental treatment. At the current time, it's about 60% of the checkups that we do in adults lead to no further care. In children, it's actually higher, and that's because we are getting the Design to Smile messaging through now about the use of fluoride. And so for us, it's ensuring that we get the right start for the children through the Design to Smile. We are educating the parents, which is why we're reaching out to you. And it's making access in some of the inaccessible areas are some of the policy elements alongside the wider ones, such as the sugar reduction.
Brilliant. Thank you. Yes, definitely a fantastic question. Just to mention to everybody, obviously put questions in the chat. Rather, we're not having any oral questions today. We're doing it all through the chat. But also, there's lots of different resources being put into the chat as we're speaking. Anything that Andrew's referring to, we're putting in. If he's happy, then we will share the slides with you all afterwards, and also this is being recorded and will be on the Child Health in the NHS Executive website, so we'll be able to send you all the link to that so that you can share this. We want this to be just the start of the conversation, and recording this is a really important part of that. Anyway, without further ado, I'll go back to the questions. So Thomas Coles has asked, brushing before or after breakfast?
Thanks, Thomas. Yeah, absolutely. The standard advice is to brush before breakfast, and this is linked to the complex area of oral microbiome, and obviously, as we're asleep normally for around about 9 to 10 hours, most people spend in bed from brushing their teeth, going to bed, and then waking up. That oral microbiome is being very active. A lot of people are mouth breathers. A lot of kids, because of large tonsils, adenoids, are mouth breathers. And so we tend to find that we accumulate a lot more bacteria before breakfast. When you go and have your breakfast, it pushes those bacteria straight down between the gum and the teeth, and that can establish ongoing oral health issues. So the standard advice would be brush for 2 minutes just before you have your breakfast. If you have lots of deposits after breakfast, and obviously brush again. We do encourage in adults the interdental cleaning, because whereas children tend to see more decay on the tops of the teeth, where we have the little fissures, the cracks on the tops of the teeth, in adults it tends to be in between the teeth. So we encourage more interdental cleaning in the adults. But if we can do it ideally before breakfast, and just before going to bed, that's ideal. In young children, it's a nightmare trying to get them rounded up and ready for bed. So, and particularly if you have more than one child, then sometimes doing a family-wide toothbrushing before they go to school and just before they go to bed is a suitable compromise, as long as they do it twice a day.
Fantastic. That's brilliant. So I shall continue with the questions. So Lisa Daniels has asked, I'd be keen to look at work around access to dental care for children and young people with diabetes in Wales. Are you aware of any specific work in that area, Andrew?
Yeah, so this feeds back. Well, not sorry. Let me just take the helicopter view. This feeds back to the work that is being done through the Delivering Better Oral Health, and there is a chapter on looking after children with diabetes. Um, this is where the messaging to the parents should really start on diagnosis, and what we really would like to see is that children with new diagnoses, particularly of type 1 and type 2 diabetes, there should be a conversation within those early consultations about how you're managing with your child's oral health, emphasizing the whole self-care, but then signposting them to dental services. So the piece of work that we have been doing, and it will be going live early in the new year, is around an access portal. So for families and particularly children who don't already have a dentist, we're asking the public. We will be asking the public to enrol onto this access portal. Children will be given a priority, and particularly children flagged as having new diagnosis of conditions such as diabetes, so that we can try and get a relationship going with the dental practice. So there'll be a lot of comms going on around that. In terms of what are we doing specifically for children with diabetes, this is the piece of work that the Royal College of Paediatrics Child Health have started using DBOH. I was very honoured to be asked to do a workshop at this year's annual conference for the college, and I've been invited back to next year's conference to do another workshop. So there is a lot of conversation, and really what we want to try and do is to hand over some of the workload onto the teams to be thinking about how does that conversation start. We need to improve the health literacy, I think, of the parents. We're not asking non-dental teams to take on dentistry, but we are thinking that it would be ideal that they could take on some of that communication around the health literacy. And I think if we were going to do any work on this, that would be a great one, looking at health literacy. It's not something that we know a lot about when it comes to oral health.
Brilliant. Thank you. The next one's a very difficult question. Are you aware of it, from Alison Blackmore? Are you aware of any infant formulas, specifically overseas formulas, that may be high in sugar content? Because she's seen a 20-month-old who had possibly the worst dental decay she'd ever seen.
Yeah, Alison, you're absolutely right. And of course, there's always been that controversy about formula food being brought in from other countries. Now that we're a very diverse nation, and again, this is back to education. The socio-cultural aspect of some family groups is we don't really know what they're putting into those bottles. There is still the concept that they believe that the infant formula should be sweetened because it's going to make the child grow stronger and healthier. So there's a lot of stuff that we could probably do with various cultural groups around what is being added to the feed. There's also a condition called nursing bottle caries, which is when the child is allowed to go to bed either with formula food in a bottle or sweetened drinks. And that's when you're going to see this very widespread damage to the teeth. It's something which should really set red flags going for a number of reasons. One is that child is going to need some active intervention, which is going to be difficult. And this is why we see general anaesthetic still being used in young children. But also there are probably other children in the house, and what is happening to those, because widespread tooth decay in one child is going to be mirrored in the other children. So I'm really grateful that you've raised that issue. We don't regulate what infant food is used, but it is around the education of the parents. And Claire, I use a very simple mnemonic called SMILE, which people might be interested in. And S stands for say R. And I think that's what, Alison, you've already done. We're used to saying R to look at the back of the throat. If you see those horrible brown decayed teeth, that's a bit of a lead in. M of SMILE is for mothers. This is where we need to actually start having a conversation about their understanding of what they're feeding their child. I is to include mouth care in all of our conversations. That's the integrated part. L is lift the lip. And the simple thing that just to ask the mother to roll back the child's upper lip. If you see brown decay on those front teeth, then the back teeth are definitely going to be decayed. So lift the lip is a very important screening that parents or anybody could do. And then the final is E, and we talk about MEC. This is making every contact count. So I just think there's a great opportunity there to have a much deeper conversation rather than to say, I've seen a load of horrible looking teeth. How do I get them in to see a dentist? It's more now a focused conversation with the parents. But great question, Alison.
Yeah, absolutely. There was one question that I particularly wanted to ask myself, because I'm aware of something that Andrew and his team are doing that actually we all need to know about, which is really about what happens when what advice can we give as non-dental health professionals to parents about gaining access to routine dental care? So what do we do when they say, I can't find a dentist?
Yeah. So first of all, we are trying to improve that by getting health boards to allocate from this access portal to practices. We are changing the dental contracts so that it will encourage dentists to see young children. But I think as professionals, the first thing is to ask the parents, do you know that that it is recommended to take your child every 12 months to see a dentist? Because some are not socialized into that themselves. Some parents only go when they've got pain. So we can't just assume that parents know that. The second is it's very demoralizing just to say, try and find a dentist, because I've heard of people just sitting on the telephone, phoning numerous practices to be told we don't have any spaces. And I think this is where the health boards are going to be very pivotal in helping us through that access portal. If it's something that's really pressing in terms of an emergency, 111 can now help to direct to the appropriate resource. But I think not just say to parents, you need to get the child into a regular checkup. That's only part of the message. Like I've been saying today, I think it's important to say to them, do you need any resources? Do you need any help in looking after your child? And then using some of the resources in the chat, just those simple messages about brush twice a day with a fluoridated toothpaste, and you, the parent, should be doing it up to the 7th birthday, and you should be supervising them until you feel comfortable that they can do it themselves, are all part and parcel of that messaging.
Fantastic. Well, I have to say, unfortunately, we're at our time and we haven't got time
Yes.
for all the rest of the questions. We've got a couple more slides, which is just for us to get some feedback and also for Andrew to get some feedback, but also to find out what you'd like us to cover in the future. So could I just ask you all just to go back onto Menti one more time? I know that you've all got to go back to work now. So I'll just get Andrew to click onto the next slide, if that's okay. And then, yes, so basically, what will you take away from this webinar? Oh, hang on, sorry, if you go back one, sorry, just go back one. So what will you take away?
Absolutely. I think that's the key message.
There's literally only four questions. Just giving you all time to put things. It's been fantastic having you all here. It's been so lovely to have such a lot of people interested. Feels like this is the start of quite a big movement. So.
And that's it. It's to maintain the conversation. It's not a one-off. And with that in mind, Claire, if anybody wishes to reach out to me at any point, I would be delighted to hear from you.
Brilliant. That's amazing. So would you mind clicking onto the next slide now? That's fantastic. Such a lot of brilliant things coming through there. This is just on a scale of 1 to 10, did the webinar meet your needs today? So please could you just use the slider to let us know, because it's important that we aim these for everybody in the NHS to really be giving you what you need. I don't know how we know how many people have responded. So,
would you like me to move on?
Yes, please. Fantastic. Thank you, everybody. What support would you benefit from to enhance oral health in your patients? So what do you need? So you can answer in the Teams chat. I think lots of people have been saying this as we go through, and what we can do is we make sure that we've got the Teams chat for we can share that with both Mary and with Andrew from both Public Health and Welsh Government. So
that would be very helpful.
And then just the last slide, please. What other subjects would you like us to cover? Anything you want. We can we'll be doing these every 2 months for the next couple of years. So as I said, we've got children's rights, we've got the voice of the looked after child, obesity, that's a good one. Safeguarding, transition is definitely going to be one we'll be doing. We've got trauma informed Wales coming up as well. Vaping would be a fantastic one. Brilliant. Oh, this is so helpful. Thank you. And this can really get us. And if anybody's got any ideas for fantastic speakers, please just reach out to any of our team. So wonderful. Thank you all so much for coming. I'm sorry we're 3 minutes over, but I think we could have actually done a whole half day with Andrew. Andrew, thank you so much. As ever, you're a wonderful speaker to listen to, and I really enjoyed and learned a lot today. And thanks for everybody else for coming along as well. And we'll see you in a couple of months with our next one.
Thanks, everybody.
Thanks. Bye.